Hi, I'm Jeffrey Berenstein, and today I will be talking to Peter Higgins, also known as the IBD doc on Twitter. Dr. Higgins came up with the idea to use tofacitinib for patients admitted to our hospital with acute severe ulcerative colitis based on a critical gap in care for our biologic-experienced patients. For those of you who don't know Dr. Higgins, he's a professor in the Division of Gastroenterology at the University of Michigan. He's the director of the IBD program, as well as the director of the Michigan Clinical Trials Support Unit. Most recently, he was the chair of the AGA IM IBD section at DDW, and he was the senior author of our article, Tofacitinib for Biologic-Experienced Hospitalized Patients with Acute Severe Ulcerative Colitis, a retrospective case control study, which was recently accepted to clinical gastroenterology and hepatology. So thank you for joining me. I'll start with our first question. So what was the rationale behind using tofacitinib for acute severe ulcerative colitis patients?
So we were hitting the wall on a couple of things. We found that one, rescue therapy with infliximab, even at accelerated doses, was not nearly as successful as we had hoped. A lot of times we could get people out of the hospital, but they would come back and come to surgery within 90 days, and our surgeons were pretty frustrated with us. Two, we were getting a lot of transfers and folks who had already been on either prednisone or IV corticosteroids before they even got to the hospital. And our standard protocol was 72 hours of IV steroids, but that seemed kind of silly in somebody who had already failed steroids somewhere else or had already failed biologics. And so for the folks coming in really hot, it really seemed like we had to do something better and something that would act quickly.
Interesting, makes sense. Why did you decide to use tofacitinib to treat acute severe ulcerative colitis patients up front rather than as a rescue therapy for those patients who failed 72 hours of steroids?
So some of this is just over years of experience. We've seen that people with acute severe ulcerative colitis build a certain amount of immunological momentum. And these folks tend to really progress if you don't get that inflammation under control quickly. We knew that tofa, from the recent studies that we had been involved in, could reduce rectal bleeding by 3 days. So the onset of action was really fast. We knew that there was a possibility that they had not reached the ceiling of tofa effectiveness because it looked even better at 15 BID in the phase 2 trials. And we knew that the half-life was pretty short, about 4.5 hours. So there was a window to choose something like 10 TID to try to get more effect in these really sick people.
Gotcha. So a lot of clinicians are excited about this therapy. So what kind of advice can you give to them before starting tofacitinib? Is there any test that you'd recommend they complete before starting it?
You know, in general, in our University of Michigan Severe UC protocol, which is freely available online, we're testing people for C. diff, for other infections, and as soon as we can, often the next morning, getting a flex sig to biopsy for HSV and CMV. However, in these really sick patients, I wouldn't hold steroids or tofacitinib to wait for the results. If you have somebody with a high CRP and low albumin, we generally start this and wait for these. We still do the tests and we wait for the results to come back, and we might change direction. But generally, if you're seeing somebody who's got blood in more than 50% of their bowel movements, they might also have an infection, but it's probably not an infection alone. They also have a UC flare. And we've learned over time not to pull back the brakes too hard on somebody who's having obvious bleeding, even if they have C. diff. We'll treat both. But we've found that if you treat the C. diff alone, if somebody's having significant rectal bleeding, they're going to have trouble and you're going to need to treat that UC flare.
Gotcha. And what dose do you recommend patients starting? Because I know in the study they did both 10 twice daily and 10 3 times daily. What duration? How do you decide when to stop?
Right.
What advice can you give to our?
And this was an uncontrolled trial. This was not randomized, but we found a significant difference between the folks at BID and the folks at TID. TID did a lot better. Now it's possible QID might be even better than that. On the other hand, it might have a new safety signal. So at this point, BID doesn't seem to make a difference above steroids alone. And that may be that steroids are pretty good and you're not really getting better than IV corticosteroids with BID. It's a pretty big difference between BID and TID, honestly bigger than we expected. But it does seem clear that TID has better outcomes or is associated with better outcomes.
Okay. And do you think that this study has the potential to change practice for clinicians managing these patients?
I have to say I'm a little bit reluctant to say it can and should change practice because I'd really strongly prefer to see a proper randomized controlled trial. That's the only way we're going to know for sure that we're not just getting odd biases in our selection of patients. But I think it's encouraging and certainly hypothesis generating. At one point, Pfizer had funded a prospective multi-center RCT, but with COVID, we couldn't recruit. And they basically pulled back the money to make a lot of vaccine, which makes a lot of sense. But hopefully, this is something that will get addressed in a multi-center trial and really answered for sure.
And you touched on this a little bit, but what other major limitations should readers be aware of when reading this article?
I think, this is an empiric protocol that we developed over time from basically quality improvement and seeing what worked and what didn't. This is certainly not the final answer. We certainly, if you expose more people to it, this is only 40 so far, we may see significant adverse effects that we haven't seen in the first 40 patients. So I think real consideration of that is important. While the half-life of tofa in the serum is only 4.5 hours, the biologic half-life is a lot longer. So I think people should be very careful about combining this with other therapies or sequential therapies like anti-TNFs or cyclosporin. I think if you're going to commit to this approach, this is your approach. And I think rescuing with anti-TNF may be a bad idea. Rescuing with cyclosporin may be a bad idea. We don't know. Generally, we commit to this, and if it doesn't work, these folks are going to surgery.
And you touched on this a little bit too with the planned RCT, hopefully in the future, but are there any other necessary steps or future directions that you see this going?
I think we need to figure out, is things like, could QID be better? Could UPA be better? Or some other more specific JAK inhibitor be better? What and how long do you do this before you can taper down? Currently, we're basically continuing TID along with the IV corticosteroids from the day of admission until the CRP is less than 10 milligrams per liter, and then tapering down to 10, 5, 10, and then 10 BID. And then, of course, converting to oral steroids before they go out. So can be, 3 to 7 days on TID, depending on how sick they were when they came in and how long it takes the CRP to come down.
A big other question is there any thought in your mind that a small molecule rapid acting like tofacitinib or upadacitinib could potentially replace steroids in the future because of its rapid onset, better safety profile? What are your thoughts on that?
I think that's very likely. And I think, it may end up being a equivalence trial where the difference, the important endpoint is the safety or adverse effect profile of a rapid acting JAK inhibitor compared to corticosteroids. I think at least on the safety and adverse event profile, I think it's very likely that a rapid acting JAK would be much better than corticosteroids. And I think the efficacy is quite possibly similar and speed of onset. So that may eventually, if we can do the prospective RCTs, turn into a new strategy for outpatient flares.
Well, that's very interesting and definitely food for thought. So thank you so much for answering those questions, and hopefully we can see an RCT registered soon.
Thanks.